But from data that I'm going to show you in a few minutes, I formed the opinion, and it is only opinion at this stage, that it goes further than that, and that what we're looking at, in my humble opinion, is that these are features of a condition that we weren't aware of before, we're becoming aware of now. And this has been one of the problems. So, how two diseases became one after 42 years is the next heading. And this is quite interesting because it's a tale of two disciplines within medicine. They both were, interestingly, published from two hospitals in my home city of London. Had nothing to do with that part. One by the genetic fraternity, sorority, and one by the rheumatological one. I happened to be, at that very point in time, in the late 60s, entering my training to become a rheumatologist at Hammersmith Hospital, you see on the left, which was where the Hypermobility syndrome was published in '67, and Peter Byton, who had been working with Victor McCusick, was installed in St Thomas's Hospital, the other side of the river, at that time, and that's how we got to know one another. Now, the hypermobility syndrome, when it was published, was considered, as I said before, to be a purely musculoskeletal problem. And one of the problems with the original publication was that in the last, the sting was in the tail, because it's stated that these were people who were hypermobile, who had extra joint movement, but they were otherwise normal subjects. In other words, these were normal people who happened to be bendy at lungs. And that's been a big problem in the last 40, 50 years, because it's been assumed by many doctors, and I must say many of my colleagues in rheumatology still adhere to the 1960s concept that these are normal people, and what are they talking about with chronic pain and dizziness, and it doesn't figure. So they thought about the other possibility, that it was really a form of connective tissue disorder, but they discarded it for a reason we will never know. And if you follow the history since that time and compare the activities of these two teams, if you like, the geneticists working on connective tissue disorders and making great strides in the elucidation of the different disorders within the family of the heritable disorders of connective tissue on the one hand, and on the other hand, the rheumatologists, who really weren't interested in anything but the joints, and they didn't really look beyond the joints, not even, sadly, to the skin. This bit was very painful to me. And as you'll see on this slide, if you can see, particularly looking at the bottom half, as the studies came through, you could see that they were looking closer and closer like one another. Not identical, but we found that autonomic dysfunction was seen in the joint hypermobility syndrome. It was also seen in the EDS group. I think it was Howard who published about the gastrointestinal symptoms in EDS, and Qasim Aziz, who's sitting here, discovered the link with joint hypermobility. And as time went by, it looked to many of us, but not all, that they were perhaps really one and the same thing. And it was up to Brad Tinkle, who got a few of us together, including Howard and myself, and we put a proposition to the American Journal of Clinical Genetics and said, we can't distinguish between the two. We can distinguish between these two conditions and other forms of EDS, classical, vascular, so forth, but we can't tell them apart from one another. And this paper was published in 2009. And looking back, I was very glad to be part of that. I don't know how you're still glad to be part of that, but the paper was really not directed towards causality. It was really to state, we can't tell these people apart. Why are we spending all this time arguing to call it this or that? What we need to do is to get on with treating them, and that was really important. I think people were a bit shocked at this because there was a debate raging about, is it that? And the time had come really to sweep this under the carpet and say, let's get on with the treatment that people need. So now we come to my main topic, which is natural history. It's been fairly clear to me over the last 10 years that seeing people over time, and some people I've seen for up to 30 years, and actually followed their progress and observed what was happening, and trying to make sense of it. And it seemed that there were stages. This was a crude kind of analysis of one's observations, that there was a first phase where, in the early stage, perhaps childhood and adolescence, where the presentation was one of pain in the joints and in the spine, dislocations, subluxations, the kind of things we heard about in the questioning before about fragility of tissues, ligament, sprained ankles and so forth, and then the hernia and the pelvic floor, varicose veins. So this was, with some exceptions there, to do with the musculoskeletal system. And then people started to look further afield, and around the second or third decade, perhaps in the 20s, then other things started to happen which was so insidious we didn't even notice it to start with. Pain amplification, chronic pain, deconditioning, widespread chronic pain. We knew that many of the joints were painful, many of the muscles were painful, but we didn't twig that there was a different kind of pain emerging, a pain that was non-anatomical, that was not primarily related to injury. And this is a pain that developed and became, for many people, the worst aspect of their condition. And it was associated with fatigue, and then we got savvy about orthostatic intolerance, postural tachycardia, and Pott's story. And then there was a third stage. Fortunately, it didn't happen to anything like everybody, but it happened to many people, that there's a phase of what I've labeled here as psychosocial sequelae, anxiety and depression, putting on weight, lack of mobility, lack of capacity for working, social isolation, resentment, anger, and in some cases, real despair. And you see, doctors who merely think this is a problem of loose joints have great difficulty in taking all this in and digesting it. They don't, it's outside their capacity. It's outside their understanding. And of course they often come to the wrong conclusion and misinterpret these symptoms as being exaggerated, fabricated, and even worse. And this causes immense suffering, needless suffering in this community, our community. Oh, what's happened down here? I've lost the slide. Thank you. So we're talking now about bringing things up to date. And Marco Pastore wrote in a paper he published in 2013, but he really hinted that this is the time where we don't just describe people's musculoskeletal and skin problems, but the chronology of symptom development, transition and evolution. This is how he described it. So what I've done, and the rest of my talk is really devoted to trying to establish through patient symptoms what we can learn from just logging their symptoms, listening to the patients, and looking in particular for 3 clues to complications. One is chronic pain, one is dysautonomia, the other one is gastrointestinal dysmotility. What we don't know, we know they exist, but we don't know how common these 3 complications are amongst our patients, whether they tend to occur in the same ones, or different ones, or different subgroups. So what I'm going to talk about is an audit of symptoms that was undertaken in patients I saw personally over a 2-year period in the Hypermobility unit in London. And for every patient, 65 sets of information were documented and tabulated. And I'd like to thank my son, Joe, who helped me with this, because he's a wizard with the spreadsheet and I'm not. And this is the form I use for collecting the information. And over this period, I personally saw 250 adults over 18 and 250 18 or under 18, sorry. And you can see there the numbers. There were far more adult females than adult males, ratio nearly 8. With the under 18s, the ratio was quite different. The female preponderance was much reduced. And these were the ages. I don't need to bore you with that, but it fits with those criteria. And what we were looking for were symptoms relating to gastrointestinal problems, and we took particularly these 4: gastroesophageal reflux, constipation or diarrhea, or IBS as it's sometimes referred to, abdominal bloating, which we know is perhaps the most frequent symptom in GI tract in EDS, and pain, abdominal pain. And for dysautonomia, we took 3 symptoms: orthostatic intolerance, which means not being able to stand up for any length of time without feeling faint. Pre-syncope means before fainting, and then the other one is palpitations. And in chronic pain, we took 3 symptoms: a life-dominating pain, fibromyalgia, and whole body pain as the markers for chronic pain. And these were the figures. I don't think the figures are going to tell you very much, so let's go straight to percentages. And we can see the percentages of random, non-selected, consecutive patients, adults and under 18s with these symptoms. And you'll see that they're actually quite substantial, up to 72% with bloating, over 50% for all of the GI ones, over 50% for all the orthostatic ones, all the autonomic ones, and just under or around 50 or over 50% for the chronic pain. So when you look closely and you construct these diagrams, thanks to my son, you'll see that in the middle of all these three bubbles is the overlap, where it means that these are the people who have symptoms from all these three areas, and it shows 64.4% for adult females, 38.3%, there are very few adult males, so it's an unreliable statistic. If we go to the under 18s, we've got 38% have all three symptoms in the females, and in the males it's at the bottom at 20%. So it does mean that the substantial number of people are actually having symptoms suggesting that they've got all three complications. Comorbidities, as some people prefer to call them. So what can we deduce from these data? Well, I've summarized it. It's 2/3 of adult females have all three, 40% of adult males and 40% of under 18 females, and only 25% of under 18 males. And I suggest here that anyone who's looking after patients who have symptoms with EDS, who talk about, who proffer suggestions of symptoms in one area, should also be questioned very closely about the other two areas. This merely summarizes the study. So there were 500 patients, and it would appear that the symptoms suggestive of chronic pain, gastrointestinal dysmotility, and dysautonomia are highly prevalent in all subgroups, though less so in males than in females, and less so in the under 18s than in the over 18s. So two questions I want to leave you with, and they are only questions at this moment because this is not a scientific study, this is merely an audit of symptoms. Does it mean that those who get chronic pain or GI dysmotility or dysautonomia are also at higher risk for getting the other two? And can one also argue conversely that those who are not getting symptoms in these three areas are at lesser risk of getting either of the other two? So I conclude, since we're in the town of Baltimore, I want to pay homage to William Osler, who sort of is the father of modern medicine. He was one of the founders of the Johns Hopkins University, the medical school, and one of its first professors of medicine. He used to tell his patients 100 years ago, listen to your patients. He used to tell his medical students, listen to your patients, they are telling you the diagnosis. Well, I wish. Thank you very much.
Dr. Grahame, thank you for your presentation. As a patient, so a takeaway from this back here, hi. My name is Raina Love, I'm from Atlanta, Georgia. As a patient, is a takeaway, if you're experiencing one of the 3 additional symptoms, it's worth investigating into the others.
At least thinking about the others and not missing them by not asking about the others.
Okay.
I didn't go as far as saying investigating because haven't got to that stage yet.
Okay. Thank you.
Hi, Dr. Grahame. I'm Heather Purdon. I'm a physical therapist from Portland, Oregon. My question is, who's being charged with diagnosing these patients? In Oregon, the doctors were like hot potatoes, and they're throwing the potato from doctor to doctor. The geneticists don't have time, so they throw us to the rheumatologist who say it's not their area. They throw us to the pain doctor and say they can't really help. My argument as a physical therapist is that PT should be on the list of people who are diagnosing, because goniometric measurement is our tool. And it's really easy to miss a hypermobility if there's a muscle tension issue over top of it. Knowing how to take that out while measuring is really important, and that's what we do. So I hope that the group that's deciding and puts out words to the doctors will put it out to the PTs as well.
It's too important to be left to doctors. In the States, the rheumatologists have turned their back on hypermobility. They are not interested. They've got other things that keep them busy, happy. And this is very sad, and I've been to 7 EDNF meetings now, and with the exception of one famous rheumatologist who is a friend of mine, I've never seen any American rheumatologists attending this meeting. Now, I think this is sad, and I think it's going to change. I'll tell you in confidence. So I don't want this on Facebook. A month's time, less than a month, I'm coming back. I'm coming back to this country to give a lecture to a group of health professionals who've asked me to come and talk to them about hypermobility. I won't tell you who they are, because that will reveal confidences. Because I think, and it's not therapists, because I think we've got to find other ways of getting voices heard and treatment administered. And I think, as I said before, we've got to find other ways and not leave it to the doctors. I think they'll come along. Once their colleagues who are there, allied health professionals, will make it clear to them how to diagnose it. It's not difficult to identify hypermobility. It's not difficult to do that skin test I showed. And it's not difficult to measure to see what the arm span is compared to the height and the high arch palate and so forth. It's easy peasy. And I'm not denigrating health professionals, I'm sorry. But it's within the grasp of so many areas. I mean, we're seeing throughout medicine so many instances where the involvement of allied health professionals can transform things. Think how pharmacists nowadays do so much more than they used to. They used to make up medicines. Now they're counselors about taking drugs. They're very knowledgeable about drugs. In the same way that therapists give injections, and it's expanding their scope, their activity, and expanding their satisfaction because they're doing more to help their patients. I'm sure that this is the way forward.
Hi, I'm Michelle. I'm a mom of an EDS patient. She's 13. So one of the things I'm interested in is I noticed on the slides that you had spoke of progression, that it's a progressive disease. We saw some stats on 18 and over and some stats on 18 and under. Are there any studies going on as far as documenting what the progression may be? Yeah, I guess that's my question.
I don't know if there's some studies. I don't think so. I think studies tend to be sort of snapshots of the situation at one point in time. We need studies that carry on through time to see what happens. I mean, this is just a very crude first step, but we need studies designed to answer these questions. And they're not easy, because apart from anything else, if you start with sort of 50 people with one condition, you'll find that in 1 year, so many have dropped out and you have no access to them, and it's very difficult to maintain the size of your cohort, which is one reason why it's so difficult.
Thank you.
Good morning. Becky Pepkowitz from right here on Pratt Street in Baltimore, so welcome to my city. Dr. Grahame, I was very taken by your statistical analysis and the tremendous lack of male patients. I'm curious about your thinking about this.
Yep.
Is this because doctors are not diagnosing men, because men are not seeking treatment, or do you think there really could be a difference? And how does this play out in families? And because of my orthostatic intolerance, I'm going to sit down for the answer.
Thanks for that question. I think it's a very interesting question. And one of our problems is we have so little epidemiology, because the epidemiologists who followed the rheumatologists have also abandoned this area, and that's very sad. So we're beginning to learn a little bit more about the prevalence of hypermobility type EDS. We haven't got hard data yet, but there was one very interesting study published in the UK about 3 years ago, looking not so much at EDS because they didn't know how to diagnose EDS, but they were looked at people. There was 12,000 people in this population, and they looked at chronic pain and they looked at hypermobility using the 5-point questionnaire. And if you take the proportion of people who had, on the one hand, hypermobility and chronic pain, so it's a kind of snapshot of EDS, it comes out about 3% of the population, which is enormously higher than the 1 in 5,000 that often banded around for EDS. Now, I did a study 10 years ago in a rheumatology setting. I took several hundred patients who came to this clinic, general rheumatology, and analysed their problem and arranged treatment and so forth, the diagnosis. But what was, I also looked at who had EDS or joint hypermobility syndrome using the Brighton criteria. And there was a difference between men and women. There was also a difference between people of different backgrounds ethnically. And I'm certain that these two factors play a very important part. I think it is less frequent in males and in females, and we couldn't look at the whole spectrum of ethnic backgrounds, but we could look at Caucasian versus non-Caucasian, because in that part of London where this study was being performed, there was a very high prevalence of people who were of non-Caucasian, so we had to lump people together, which is not very nice, but there's no doubt that these are factors. I don't think it's because people don't come forward. I think it affects probably females more than males, but there may be other reasons for that.
I want to thank you again for your 50 years of research into this and for continuing to try to educate the medical community even when you feel like you're banging your head against the wall.
I've got nothing to lose. I can, I don't mind speaking up.
Well, my thoughts today are about communication and how we can communicate with our doctors. And I've done some trial and error. And as a patient reports what they have learned at a conference, the doctor is highly suspicious that they may have misremembered the information or may have just found us on Google or something. I've found that the greatest response that we can get from doctors and to help spread the awareness is if we can get a peer-review article. And if we're concerned about dysautonomia or if we're concerned about neurological issues, if we just highlight a few points of what our concerns are, the doctor is a lot more responsive to that. So my question is with the Ehlers-Danlos Society, as a patient, if you go to look for a medical article, sometimes you are only given access to the abstract. And you really need kind of the whole document. If the Ehlers-Danlos Society may provide links at some date by subject matter so that we as patients are able to print those off and take them to the doctor, or as newly diagnosed come on board and we are on discussion boards and someone is concerned about an area, we can post that link.
Rodney, should I answer this one?
Yeah, please.
Hello. I saw your face, I thought I'd take over. So, yes, always as a patient, I know what it is that I would want to go and find. So, it's very important that we have, what we wanted to do with the society is have almost a one-stop shop. So we don't want to do the job that the national charities are doing very well already. It's not about that, it's about just having it all in one place so that you don't have to then do the work to go elsewhere. And I think it's very hard for us to get articles that don't have free access. They're like that for a reason, and some things are not for the lay community to read. But what we're setting out to do, and what the entire purpose of this symposium was to publish a free accessed article that's going in the American Journal of Genetics that everyone in this room and everyone in the medical community can read. You can print it out at no cost. You can take it to your doctors, to your caregivers, to your friends, anyone. And we are also publishing a lay version of that, which will be a little bit more of a succinct abstract so that people who do struggle with medical language can also understand that. They will live on our website. They will also live on the National Charities website. We have no intention of keeping that information just for us. The whole purpose is to put it out there to as many people as we possibly can. In the interim, we understand that there is time between now and March, so we are going to be turning to our medical board to create articles that will be published by medical professionals for the charity that you can use to take to medical professionals, which will be written by the right people. They won't be peer reviewed in the same way. But this article that we're publishing is fully peer reviewed. It's written by an international consortium of doctors. And frankly, if that's not enough, I don't know what is.
Thank you.
It should be like, as they said, they're having a hard time getting their consensus together with a lot of things, that if the medical board can publish one article, that if a doctor has somebody that comes to them or diagnosed with EDS, that they could say, okay, we have somebody with EDS, what treatment recommendations does this board make? What do you look for? If it's one article,
Good.
I didn't hear you.
Microphone.
It is one large article with chapters. So each committee has a chapter, each group has a chapter, but it is one supplementary article in one place,
Right.
for everyone's
And it should be labeled treatment recommendations.
It is the diagnostic criteria for EDS and the management and care guidelines.
Another thing, like my mother has EDS and her osteoporosis is very, very bad. And she was very myopic. She had Coke bottle glasses, and now she has glaucoma. And she's like, you know, I just hope I don't go blind before I die. I'm not really interested in seeking other other treatments other than just going to the eye doctor and such. And I think there's this mindset of the older people that, you know, it's just too much, or if I complain, I'll get drowned like a bad puppy. You know, if you speak out too much, it's just hard to see the hopeless. I mean, and men are even worse. I mean, it's trying to get these older folks who are already really struggling to come and seek attention, because the doctors aren't going to seek you out. And it's just really hard to convince them to seek the treatment. And another thing that's come around, like in hospice movement and such, the pain is what the patient says it is. You rate the pain on what the patient says it is not, and you treat for the pain. But as he said, you should look very carefully and try to determine why, and now they have all the treatments available for it.
Thank you so much. As our strapline says, our strength begins with hope. So we are hoping for a better day for everyone, every generation that there is. But thank you. I'm going to pass back to Rodney because we've only got a few minutes. It's late.
Hi, my name is Kari Aiken, and I'm from Big Fork, Montana. And I was struck by your slide that showed the difference in the skin between somebody that doesn't have Ehlers-Danlos and somebody that does. I am wondering if it's possible to look at a biopsy of your skin or look at the collagen that is in our bodies versus somebody that doesn't have it, and use that as a diagnostic criteria, because when the collagen show up as different, and
it's not that different, actually.
It's not?
No.
Okay.
I mean, you could see them as different in the electron
Yeah.
microscope, but on the ordinary microscopy, it's not that different.
But couldn't you use the electro? I mean, that's not something.
It's not, but it's not. It's not a diagnostic thing. It's not strong enough.
Okay. Huh.
Hi, my name is Dina. I'm from Wilmington, Delaware. My question is about how to present secondary conditions to doctors, because, you know, I can go in there with like a laundry list of diagnoses and symptoms and problems, but like, that's not, I mean, I want to be able to go in there and say, like, no, I have the kind of GI problems that people with EDS have, I have the kind of allergies people with EDS have, the kind of dysautonomia people with EDS. Like, you know, is there a way that, you know, you recommend talking to medical professionals so it's not like an overwhelming, like, rainstorm and it's more of a cohesive package?
Well, it's very difficult to try and teach doctors. I do feel for you. I really mean that. They don't take to it gladly. I don't know the answer. There are many doctors who are open-minded, hoping to learn. I think being a doctor, you never stop learning. But some people seem to feel that they know it.
Is it fair to describe these things as secondary conditions?
You can try.
Okay.
Hi, my name is Lee Soni, and my daughter is 10 years old. she was diagnosed with hypermobility syndrome. And I was just wondering that is there any guidelines for schools that they can better understand what it is, what it comes through? Sorry. So I did some research from the Hypermobility website from UK and got some school guidelines, but I would like to see if the Ehlers-Danlos Society can actually come up with some school guidelines that can really help the school system in the US, and really if the school boards kind of look forward to, adopt that policies and procedures.
Sandra's going to take this one.
These are things that we're constantly working to update, but there are some guidelines on our website now. And if that's not enough for you, perhaps we can try to get you in touch with some experts. But these are things that we're constantly working to improve, but there is existing information on our website.
Hello. Hello. My name is Edwina Chen. I'm over here in the front.
To your left.
Over here. I have a very different kind of question. I don't know if this now is the time for this group to be thinking about it. I'm just putting something in their ear, which is how long did it take for the medical insurance billing codes in the UK for EDS to be adopted? And do you have any advice for the American public and us as a advocating group to lobby our Congress members and for patients?
We have a completely different healthcare system in the UK, and I don't know how to answer your question really, because we're not. I mean, we have a state system.
I understand that. But was it immediately adopted as soon as you came up with the diagnosis?
Well, but we're not doing very well.
Oh, you're not doing that's actually what I was asking as well.
Same trouble.
Okay.
Same trouble, it's okay.
I'm really sorry, we're going to have to call it a day there. Thank you so much to Professor Grahame for everything. Thank you. And can I ask everyone to get their lunch very, very quickly, because we will be having